So this is a case of compression fracture. You can see osteoporotic compression fracture. She is 72 years old female. She is having two level fracture, L2 and L3. Now, if you look at this striatal section, so there's a cleft over here. This is an old fracture. So it's almost been 4 or 5 months now, but she's not been able to um, improve with this conservative management. So that's why we decided to go for the vertebroplasty. So you can see here, this is the reason why she is not improving, because there's a big cleft over here. And also, if you look at this one, L2, also you can see there's a big gap over here, and you can see a lot of good edema over there. So this edema basically shows that this is a non-healing type of fracture and it is still active fracture. Had this been totally like a dark object, in that case, that means a sclerotic kind of um, already healed fracture. But this is not a, you can see a lot of edema. This is a fat suppressed image, and you can see this is a edema. The challenge in this is a simple fracture. This is a simple compression fracture, not a very difficult case, simple case. But here you can see there's a big cleft over here. So in this, our aim should be to target this cleft. We should not try to fill the entire body, because that is not required. If you're able to fill this cleft, that gives a very good relief to the patient. Why these patient pain? Such kind of fractures are painful because of the cleft. There's a movement of the bones. Every movement is painful. They cannot even cough, cold, and sneezing is very painful. So we just okay. So one thing what I modified in this case, because I wanted to be very precise over the cleft. So that's why I did it one by one. Normally I do it, put the needles both together and do it simultaneously. But here I wanted to be very precise. I wanted to take some time over here. So I did one by one. I did first one over the L3. So you can see this is oblique. This is how we go oblique. We go with this 22 gauge needle, go up to the junction of the SAP and the transfer process. Check lateral, see maybe now this is the trocar which goes inside, and now we have started going inside. So you have to be careful about this middle border of the pedicle. So middle border pedicle, till the time you reach the posterior cortex, we all know that. And we can see from here, there's a cleft over here. So this is what I'm intended to fill over here. So we start going like this, deliberately keeping my bevel downwards, so that the cement should not directly go into this cleft. Now we start injecting the cement. And now you can see here. So here's where we started filling the cleft. You can see here, that's the cleft. You have to carefully wash the anterior border of the vertebral body. You should not, the cement should not leak from the anterior body. And so this is, you can see here now, this portion I nearly filled. Now it's started coming back. We started filling this cleft over the remaining cleft. So this is for the, now you can see this AP view. This is where the cleft was. You saw in the MRI, and is completely filled with, this body is active. We don't want to disturb this part. We just wanted to fill the cleft over here, and that is what we did. And this is the second upper level. You can see that's a very simple case. You can go with this. So don't worry about this. There is something here. There's something here. You can see something here. Okay. Don't worry about this. This is not a cement leak. This is not a cement leak, because this is the cement which is outside the body. So there was some cement leak outside the body. So it was, this cement was lying there. So I just removed it so that there's no confusion. But this is how we are filling it. Again, this is not a leaked cement. This is just outside. cement portion which is there. And you can feel this entire vertebral body. This is just a simple case of vertebroplasty. So whenever you have 2 level, 3 level, you have to decide if you are going to take some time. It's a simple compression fracture. It doesn't take much time. In that case, we can do simultaneously both together. But if it is like a cleft, you have to take time. You have to fill the cleft. It, so better not to do it simultaneously. The only thing is because the cement fixes very fast. So what normally I do in such cases, whenever I'm doing separately, I keep half of the cement and half of the fluid, the solute outside, and so that I mix only half portion first, and then for the second level we mix it later. So that is the modification what you can do. So that is all. Patient had a very good relief. Just did work procedure. Patient is walking now. She was in severe pain. She came in stretcher and walking and a wheelchair. She's very happy, and um, I know this is one of the best procedure. We all know that it gives instant relief to the patient. Only thing is you have to be careful about the cement leaks, especially in the posterior column. That is all what you have to see. Here you can see there is mild, small leakages over here. So that is why we stopped over here. We could have filled this entire vertebral body, but since the steam started going to the posterior cortex, so we stopped over there. So this is what you have to see. Okay, thank you so much.